to use opioids recreationally. Combined with the unprecedented availability of inexpensive, easy-to-find heroin and fentanyl. The drivers of this epidemic are easier to identify than to resolve. This is a deceptively complex epidemic. Many groups across the state have been coordinating to address the epidemic for many years. North Carolina has made progress, we've had successes, and we have more work to do. This is just a little picture that we used to try to frame up how we work on the opioid epidemic from a public health perspective. And I readily recognize different disciplines have a different point of view on what with their approach and strategy. So I often like to try to frame how public health works at this issue. And we're focusing on the health consequences of the use of opioids, from deaths, emergency department visits, and disease spread. We recognize that others are taking the lead on the behavioral health impact. We recognize that there's law enforcement, criminal justice, corrections impact, the social services impact of family destruction, foster care services that are an unprecedented high rate right now in the state, and that the demand for public services across the spectrum is being diverted to address the epidemic that could go to other purposes, whether it's chief medical examiner, EMS, crime involvement, and so forth. So hopefully you'll see by the end of the talk that we have an effort in the state that are coordinating across the spectrum. Other thing I like to point out is injury prevention, and I often say, well, why is he often offer to folks, so why is injury prevention and public health working on the issue? Well, whoever decided how to divide up health in this world said an overdose is a poisoning, and a poisoning is an injury. So the injury prevention branch, we used to call this poisoning deaths, and it still falls into that category, but to offer that frame of reference that we work on this. And our efforts primarily focus on the death in the hospitalization and emergency department while we coordinate with others. The things that the injury prevention branch does, I often say there's three main functions that we do. Epidemiology, and a lot of the data slides that you'll see later is what we do. We convene with a broad group of partners to try to bring people into the room together to talk about the issue, and we focus on the evidence-based strategies, practices, and policy. We're one of the states that received the big CDC funding to address the issue. So to go with my theme earlier about 20 years of treating pain with opioids, this is a perspective from North Carolina, the historical trends on injury. Motor vehicle and firearm injuries are the intentional and unintentional. Historically, the issues that kind of drove the injury field. Poisoning, this is a chart from 1968 to 2015. Poisoning deaths were relatively a low issue. The big change in the environment was 1989. The medical profession in North America decided to add pain as the fifth diagnostic test. Following that addition of pain, the pharmaceutical industry cranked up manufacturing. 2001, JCHO added appropriate treatment of pain to the accreditation process, and we've seen the dramatic increase in poisoning deaths or opioid-related deaths. So in 2010, poisonings overtook the historical leading causes of injury in North Carolina to be the leading cause of injury death. And we'll break down what poisonings are and so forth in a couple slides down the road. So the question that often comes up, well, is there a correlation with the opioid sales? This is a national picture. North Carolina's pictures, county pictures mirror this. As the sales of opioids have gone up, opioid deaths have gone up. We can mirror neonatal abstinence syndrome on it, but this is the simplest way to kind of show that from an epidemiologic perspective, the correlations with sales is up. Where does North Carolina fit in the states with opioid sales? We're number 13 roughly in terms of prescriptions per population. So we're near the top tier of states in that. This set of slides, I've included a separate set for Area L AHEC. This is based on some presentations I did recently. I often go out and talk at different community groups. So this is also to show that if you're with a group that's interested in looking how the data impacts you, we can customize slides locally. But with that said, this is a complex slide, but what it really combines two functions. The dark dots on this slide by county is dispensing per county. The darker color is deaths per county. Bigger dot, more dispensing, darker color, more deaths. And you can kind of see more or less that that trend continues across the state, more dispensing, more deaths from opioids. One of the things I said in the sort of the framing document is not only are we dealing with the consequences of changing the dispensing practices for opioids, we've eroded a historic hard wall inhibition to use opioids recreationally. And I'll say in my day, you can't see me, you don't know my age, I'll say I have kids in my late 20s and 30s. In my day when I was a teenager, my cohort, if you wanted to go find something to experiment with, you went to your parents' liquor cabinet. Now kids today go to the medicine cabinet, because one of the consequences of the prescribing is lots of pills are available that are unused. So now in North Carolina, we have about 20% of high school students, we're at graduation this week, about 20% of the students graduating this week have tried opioids recreationally, where a generation or so ago, you have to work to find the availability of opioids. So we have a problem that we're in for kind of a long haul. It took a generation to get into this, and we don't want to lose a generation to get out of it. So I'll transition the presentation from the framing part to a little bit more into the data piece of it. This is one of many slides we have available, because the question often comes up, is this illicit drugs, heroin, street drugs, is it prescription drugs? And the next few slides help try to frame out that the prescriptions, which is the top line here, the green line, is still driving the epidemic. Over time, this epidemic has changed. We've seen the red line is heroin and that combination of synthetic opioids. I have a couple slides that'll say we're in a transition phase the last 2 or 3 years where heroin has made a big comeback. In 2010, we had 39 heroin deaths in the state. We're 364 in the last, 2015 was the last available year. We think 2016 will be moving up even higher. So we may be 50-50 in the past year of prescription opioids to illicit opioids as we're in this transition. And then that darker bar on here is synthetic opioids. About 3 years ago, the manufacture of illicit fentanyl started, in the importation through the drug cartels and all that wonderful stuff that you can read about in the news has made fentanyl widely available. Cocaine is on the rise also, but in summary, this is a snapshot that still is the prescription drugs, and as I said, the availability of prescription drugs has allowed folks to sort of consider the use of illicits recreationally. It's eroded that hard wall of inhibition. This is another way of looking at the similar set of data, just matching up heroin, fentanyl, and that fentanyl is not pharmaceutical fentanyl, it's illicit fentanyl sold on the street. And then the green bar is what's happened in the last 3 years is analogs of fentanyl have made in there. You probably have heard in the news elephant fentanyl and carfentanil, and OCME has a Chief Medical Examiner Office has a very complex chart showing the different fentanyls that are out there, but that's making it into the market. Just another quick slide I'll go through here. Since about 2000, when we kind of recognized this overdose epidemic, the drugs that have been the drivers of the epidemic have changed. This is the heroin trend, a little crude way of kind of showing the swirl of changes. Cocaine was a big player, it's coming back up. Methadone, and this isn't opioid treatment methadone, this is methadone that was prescribed for the treatment of pain. Very cheap, inexpensive drug, highly lethal because its half-life stays in the body a long time. So fortunately, Methadone has been taken off most of the formularies, but unfortunately it's been replaced by other drugs. And then the last trend is just the synthetics that have come into the market. So death is one piece of it. This chart right here shows that 20,000 emergency department visits a year, 1,200 deaths per year. And in the average county, there's roughly one overdose death per month and one overdose emergency department visit per day. One quick demographic slide. This comes up a lot, folks, as you try to figure out the population. Often in the news or the conversation is about youth and teens. Actually, you can see on here that it's folks in their 40s and 50s that are dying in the epidemic. It's more males than females, which is a common pattern in injury, and it's an overwhelmingly white death problem. Again, when you think about opioids, I think it's often easy to think about the heroin and who we often think of as the typical heroin user, but it's prescription pills that's been driving this epidemic for 20 years, and the people that have access to prescription pills are the ones that are dying. And these are unintended deaths, not suicidal or homicidal deaths. I'll kind of keep moving through the slides a little bit. This is given a sample of, we can break these out by county. In your county or your locality may have a variation within the death rates. Race we can also break out per county. So you can see, well, what's the proportion of deaths in your county or your region, and what's the proportion of opioid deaths available. This is the chart that we have that show across the state there are pockets with more death rate from opioids than others, and there's efforts to target those areas. This chart happens to be from where we worked at the area LA had to show them that chart. And then finally, I'll quickly move through this. Our office doesn't work as much on the treatment side of it, but we have data on where the opioid treatment facilities are in the state also. So I'll transition now. The second half of the presentation is a little bit, well, what has the state been doing on the issue? This is a very complex poster that I did a couple years ago for a presentation, and I'll point out a couple things. North Carolina has done a lot of work. While we're near the top of states in terms of dispensing of opioids, we're in the middle of states in terms of death. Not that there's anything to celebrate about that. It's more, I think, as we talk to folks that are working on this, to recognize there's been a sustained effort across the state since the early 2000s to address the epidemic, and I think we would be in a much worse state if we weren't actively working on the epidemic. So I kind of pull out and annotate a few points in here. It happened to be that the current opioid epidemic was identified in North Carolina in 2000, early 2000s. Wilkes County had the fourth highest prescription drug overdose death rate in the country, and just the one county, and CDC came in to do what they call an Epioid or a field investigation. Sometimes you hear this when they go to foreign countries and look at Ebola outbreaks. Well, they do it nationally also, and they came to Wilkes County, and this was sort of the first trigger that there's something going on different out there for death rates. That led to a governor's commission and finally the establishment the Controlled Substance Reporting System in North Carolina, or nationally these are known as prescription drug monitoring programs. Those tools where prescribers and clinicians can look in there. And as I often say, when pain was added as the fifth diagnostic test, when a patient comes to the clinic, what's the question on a scale of 1 to 10? Where's your pain? They don't say, well, what do you think your blood pressure is today? What do you feel that your weight is today? Tell us what you feel like your temperature is. So the CSRS is the one objective tool that clinicians have available to gauge one tool to gauge what a patient's prescription drug history is. There's other tools out there like drawing blood and all that, but that was added in 2007. We are fortunate with many great partners. We have the largest drug take-back program in the country, operated by Safe Kids and in the Department of Insurance at the state level in collaboration with SBI and many, many partners across the state. What Safe Kids has done in North Carolina has been copied across the country, and we're really fortunate, and I'll give a couple slides later on. Another highlight is the Good Samaritan naloxone access law happened in 2013. The General Assembly has done quite a bit of legislation since about 2011 to address the epidemic. I don't have a slide on the STOP Act. It's before the legislature that passed unanimously in the House this summer, and it's going to be before the Senate, we think, next week for passage. And that does a lot of things for the controlled substance reporting system, like mandate usage, mandate registration, mandated usage by prescribers with reasonable exceptions, like patients in hospice care are accepted, emergency departments are accepted. But I encourage folks that are interested to look up the STOP Act, because I think that's going to be a milestone in addressing the epidemic. You know, in a state of 10 million people, we have 705 million pills prescribed per year. And as we often say, those pills are going somewhere, because when the patients don't take them all, you need drug take back and other things. So the Good Samaritan naloxone access law, we think we have the largest naloxone or Narcan distribution program in the country, and along with the largest drug take back, and I'll have a couple slides about the impact of that. Last year, the General Assembly passed some additional legislation, the naloxone standing order, which I'll have a slide later on, the syringe exchange law, that we were the first state in the South to enact Good Samaritan laws for naloxone. We're the first state in the South to enact syringe exchange legislation. Virginia, Georgia, Tennessee have all enacted laws since then, since last summer, similar to North Carolina's law. And by legislation, the State Advisory Council was instituted last year. So a couple slides to emphasize some of the prevention strategies that are available that you can go look up at home. I mentioned drug take back. The Safe Kids North Carolina maintains a website. This is just a screen capture for Halifax County. You can put your county in there and you can see where the permanent drug take back locations are. There's episodic campaign in the spring and the fall, where you can drive up and drop unused pills. But the permanent take-backs, the goal is to have take-back locations in every county, so anybody who recognizes the hazard that those pills in their medicine cabinet pose to anyone else in their home or may visit their home, they can get rid of those unused, unwanted pills as part of it. I mentioned the naloxone. Good Samaritan law, we're fortunate to have in North Carolina, have a tremendous partner in North Carolina Harm Reduction. The law decriminalizes the prescribing and dispensing of naloxone and the reporting of an overdose. The actual distribution program, there's no funding per se in state law, just a little bit of money here and there, but through a fabulous voluntary network, we have a large distribution program on naloxone that we're trying to kind of solidify and make available. So since 2013, over 39,000 overdose rescue kits have been distributed statewide by Harm Reduction, and over 6,000 overdose reversals have been documented. We know there's certainly more overdose reversals than that have happened. That's just what's been reported. Just another graphic. If you go on the Harm Reduction's website and you click on their naloxone page, you can see lots of the data. We help package their data on our website and work with them. But this is demonstrating on this slide the almost exponential growth in naloxone programs in reversals across the state. Harm Reduction has targeted their efforts in the 3 areas in the state that historically have had the worst problem: the Buncombe County, Asheville area, the Triad area, and now in New Hanover. As you can see in the news, for some reason, national groups have identified New Hanover and Wilmington as the top spot in the country for opioid deaths. Whether you believe that or not, there's a lot of tremendous work going on in that part of the state, and Harm Reduction has been a big partner in that. One of the efforts that has been key with the naloxone law is also getting law enforcement agencies to carry naloxone. We knew early on in that early 2000 era, a study was done that showed that 64% of the opioid deaths in the state occurred before EMS arrived at the scene. EMS has been carrying Narcan for a long time, but law enforcement agencies to be able to do the rescue on the spot has been a key piece. And to get law enforcement to change, and this has really been a dramatic change. The phrase we hear a lot is we're not going to arrest ourselves out of this epidemic. We've seen a tremendous sea change in law enforcement's perspective on the epidemic. I'll mention EMS real quickly. Last year they administered over 13,000 doses in the lock zone in the state, just to kind of give a perspective of how much of their time is devoted to the opioid epidemic. I mentioned the standing order in the white lab coat on the right in this picture is Dr. Randall Williams, who was the Deputy Secretary and the State Health Director, and the governor on the left at that time, McCrory, signing the standing order. In essence, what the standing order enabled is any pharmacy in the state to sell in the lock zone directly to the public without having a local medical director to sign that. The pharmacy community asked the state to do this because, you know, if CVS wants to sell statewide, they have to go to each county or get a medical director. You can read more about it on our website. We stood this website up rather quickly, and it's been a really good resource for folks. One-stop shop, naloxone saves, saves.org, or you can do an internet search call on naloxone saves and find out all kinds of information about the standing order, frequently asked questions. We think about half the pharmacies in the state have that available. I often, when I do a presentation at community, I'll do the meeting location and then just show from the website what pharmacies near the meeting location you can purchase the naloxone at. One of the other consequences of this epidemic is increase in injection drug use and the cost and the increase in hepatitis C. This month there's been quite a bit in the news about increase in hepatitis cases. This concern led to the passage of the syringe exchange law. You know, with now therapeutic drugs that you can cure hepatitis, the Medicaid charges in the state between 2011 and 2016, Medicaid went from about $3.8 million in treatment of hepatitis to $85 million. Huge cost. A lot of that is driven by therapies now and expensive drugs. The reality, though, is with an opioid epidemic and increase in injection drug use, we've got a huge cost and health wave out there. So the syringe exchange law was part of the effort to stem this communicable disease aspect of the epidemic. CDC's MMWR published an article this week on the dramatic increase in endocarditis or heart valve infections associated with the increase in injection drug use. I won't belabor a lot about it. Syringe exchange, it's a really exciting thing that's going on in the state. Just a little bit of the language from the legislation that was enacted on exchanges. Our office got assigned the responsibility for implementation of the law. We've hired a staffer, and I think we're doing really tremendous work. So in the first year of the syringe exchange legislation, we have 23 exchanges covering 20 counties. And there'll be some legislation in the STOP Act that will increase the expansion. We think we'll double that in the next year. Really quickly, because I'm looking at the clock, and Annabeth, I know I'm getting close to time here. I'll mention a couple things real quickly and then open it up for questions. In terms of the state effort, we had legislation in the 2015 session law that mandated a state plan to prevent opioids and a coordinating committee, or what's called the PDAC. This busy slide here represents that the PDAC was stood up with a series of subcommittees, and we have over, I think the participants is over 200 folks now in the quarterly PDAC. We've stood up a resource website. We're in the middle of revising the state strategic plan to reflect the new administration that we have with the new governor that comes in. We have tremendous support from state government, from the General Assembly supporting legislation and putting dollars behind it. The governor's identified opioids as one of the top priorities. Our secretary has identified Health Secretary Cohen has identified opioids as their top priority. Attorney General Stein has identified opioids as the top priority. So we have a lot of work going on in the state and a lot of really great energy happening. And the epidemic is so large, we have a lot of folks engaged. So you can go to the PDAC site. That's the address, the web address for it down there and see some of the resources available. In less than 2 weeks, roughly 2 weeks, we have our third statewide summit on opioids. We have maxed out on registration. I would love to say go there and attend the summit. We have a long waiting list already. I would suggest, if you're interested in finding out more, to go and register and get on the waiting list, because they're going to be live streaming the plenary sessions, and anybody who's registered will in the next week or so get a notification about how to listen in, because it's going to be hard to attend now. We've got a lot of folks going. So the last couple slides, I won't try to describe it all. There's been federal funding coming out. There's a federal plan to address the opioid epidemic. The first investment at the federal level was CDC funding, which came out about 2 years ago. We were one of the first 16 states. The CDC funding addresses prevention strategies, or what they call upstream, reduce the prescribing, get community groups involved, do rapid response, evaluate the initiatives. Really quickly, some of the things that we're doing with the funding from CDC is we work with UNC Injury Prevention Research Center to evaluate our efforts. We have a contract with the Governor's Institute on Substance Abuse to provide continuing education for medical providers on safe opioid prescribing. We work with harm reduction, and many of the things I mentioned about naloxone, we're trying to work to evaluate their efforts and increase the reach that they have. And this summer, what we think is a really exciting initiative, we don't think we're going to really change the culture for prescribing unless the health systems that prescribers and the hospital culture changes. So we've entered into a contract with the North Carolina Hospital Association to convene hospitals and health systems to look at prescribing practices and look at ways that best practice and come out with an evidence-based guide on how to address prescribing. We see there's going to be a paradigm shift. JCHO and the medical community have asked the question for 20 years, are you appropriately treating pain? The question needs to change to, are you creating addictions? Are you managing pain appropriately, and are you preventing the creation of adiogenic addictions? So the last thing I think my slide is we're also fortunate that we entered into a relationship with HIDA, which is the high intensity drug unit, with the DEA folks, and we have a staffer in the office to work on data analysis. So thank you.
Alan, thank you. That was just fascinating, and I'm sorry you only had 30 minutes because there's so much more information. We do have a minute for questions, so if you have a question for Alan, please type it in the box. And I would ask you, while we're waiting for questions, Alan, just please explain what naloxone is and how it works.
So naloxone is the chemical name. Narcan is mostly the commercial name for it. It's an antigen to an opioid epidemic, and like anything nowadays, I look it up on Wikipedia and I go, what is this? So it reverses the effects. Opioid suppresses the respiratory processes. Naloxone, the way I've heard it described, is it knocks the opioids off the nerves, the nerve endings, and it almost instantly reverses an overdose. And so, you know, I often say, anybody see Pulp Fiction? Remember when they jammed the needle in the guy's chest? Well, that was atropine for an anaphylactic shock, but it's a similar sort of things for folks that are not involved medically. An opiate, we're changing how we describe this, because as fentanyl has entered the market, fentanyl is much more potent than heroin. So with heroin or a lot of prescription drugs, opioid isn't an opioid overdose isn't an instant event. It takes time. It's basically somebody passes out and goes to sleep. And harm reduction, and any of the training for naloxone programs will teach how to recognize an overdose from an opioid. The concern at the moment we're at right now is with fentanyl, the potency is so high that the time frame is compressed, but naloxone is still an important strategy, and we're working with harm reduction to get out messaging. Narcan as a company, the brand name Narcan, for folks on the call from the medical side of the world, Narcan's been around a long time, and a company in Ireland purchased it and repackaged it as a nasal inhaler, almost like what you would get for an allergy, and that's what we're recommending. There is an intermuscular Narcan available for purchase in naloxone, but for folks, the bottom line, I'll end here to say, what we try to say to folks is, if you have someone in your life, a spouse, a child, somebody that you're aware of that uses opioids, it's a rescue medication for them. It's a first aid. We have AED defibrillators virtually on every door of every floor of every building to rescue for heart attacks. Naloxone or Narcan is the drug available for someone that you know that's at risk for an opioid overdose. So go to naloxonesaves.org and you get lots more information on it.
Thank you. That's great. I don't see that we have any questions, so we'll give you just another minute because our time is up here. But we'll just give you another minute in case you have a question you'd like to type in the chat box for Al, and he'd be happy to answer your question. It's really exciting to know about all this work that's being done in North Carolina, and thank you so much to you and your team and all the partners around the state and our legislature for all you're doing to address this problem. This is really, really interesting and informative.
So, Annabeth, let me just comment. You know, I often forget as I talk about this stuff, you know, when we say the public health convening role, I want to emphasize what you just said. There are so many people working on this, and we're fortunate in this state that people collaborate and willingly share their ideas, and it's becoming a larger tent, but we're real fortunate that everybody seems to be pulling in the same direction. So I have the opportunity to share the work that's going on, but I share the work of a collective large group of folks. Our office contributes a little bit to this, but we're fortunate that a lot of folks are listening and learning and working, and lots of ideas coming together.
And it's great, you know, for those of us in public health love and in clinical medicine love to hear about partnerships and people working together on an issue as serious as this one. So thank you very, very much. Next month we will have a webinar on motivational interviewing on July 11th, and please note the time change will be at 1 instead of at noon. So thank you very much for joining.